Lower GI bleeding in a newborn diagnostic, CBC platelet count, coagulation panel, liver function test, occult blood test, shows USG, ultrasound for intersection microscintigraphy, abdominal blood can be ingested. A put-down test is needed to differentiate really between both by taking history, physical exam, ultrasound, X-ray, colonoscopy with laparoscopy if needed in macrostability, CBC, hemoglobin, electrolyte view, and creatinine coagulation studies. In lower gastrointestinal GI bleeding in a newborn present a unique set of diagnostic challenges due to the wide range of potential etiologies and the non-specific nature of the presenting symptom. An organized approach is essential for effective diagnosis and management. Characteristic of symptoms and physiology symptoms presence of fresh or altered blood in the stool may also observe signs of stress, feeding intolerance, or abdominal distension in the infant. Pathophysiology can vary widely, including other features. Allergic colitis, necrotizing enterocolitis, NEC, intestinal duplication, macrostability, vascular malformation, among others. The underlying mechanism generally involves disruption of the mucosal integrity or abnormal vascular structures within the lower GI tract. Clinical presentation and diagnosis. The diagnostic approach involves a careful history, physical examination, and targeted investigations. History, onset and duration of bleeding, color and consistency of blood-associated symptoms, vomiting, fever, lethargy, and feeding history, breast weight, or formula, fed recent changes. Physical examination assessment for sign of distress, abdominal distension, palpable masses, and other inspection for fissures or abnormalities. Laboratory tests, complete blood count, CBC to assess for anemia or infection, coagulation profile to rule out coagulopathy, blood type and cross-match in preparation for possible transfusions, two studies for blood infectious agent and possibly organ-specific IgE levels if allergic colitis is suspected, imaging and specialized tests. Abdominal X-ray to evaluate for NEC obstruction or abdominal gas patterns, abdominal ultrasound to look for intestinal duplications, volvulus or other anatomical abnormalities. Upper and lower GI contrast studies to identify structural abnormalities like marked tails, diverticulum, or intestinal duplications. Endoscopy limited use in neonates but may be considered in specific cases to directly visualize the source of bleeding. Treatment is highly dependent on the underlying cause. Management may range from conservative approaches for minor conditions like anesthesia to surgical intervention for more serious conditions like NEC or intestinal duplication. Prognosis general outlook varies significantly based on underlying cause and the timeline and effectiveness of the intervention. Condition-specific early and accurate diagnosis followed by appropriate treatment can significantly improve outcome, especially in conditions like NEC where the morbidity and mortality rates can be high. Differential diagnosis in table other features visible here in the ulnar regions, often with bright red bleeding, common, usually benign and self-limiting. Allergic colitis, blood in stools, possibly with mucus in an otherwise well-infant history of cow milk protein exposure. Diagnosis, often clinical elimination diet may be diagnosed in necrotizing enterocolitis, distended abdomen, feeding intolerance, and pneumatosis intestinalis on X-ray. Critical condition requiring prompt medical and sometimes a surgical intervention, intestinal duplication, abdominal mass on examination, cystic mass on ultrasound. Surgical resection is often required. Metals to verticulum, painless bleeding, technetium, pertechnetate scan positive. That may require a surgical intervention. Vascular malformation can be a part of syndrome. Intermittent bleeding may have other cutaneous system. Cutaneous or systemic vascular lesions. Diagnosis with imaging management varies. And high yield points on thorough history and physical examination are critical in the initial evaluation of lower GI bleeding in a newborn. The new range of potential causes is broad and the diagnostic approach should be systematic and guided by clinical presentation. Early in the identification and treatment of the underlying cause are crucial, particularly for conditions like NEC, which have significant morbidity and mortality. Careful consideration of the differential diagnosis coupled with appropriate investigations is essential for effective management of lower GI bleeding in newborn. Lower GI bleeding and newborn diagnostic CBC platelet count coagulation panel liver function test occurred blood test of stool. Ultrasound for intercellular microcentigraph maternal blood can be ingested, so up-down test is needed to differentiate between both by taking history, physical examination, ultrasound, X-ray, colonoscopy, laparoscopy if needed in mucous diverticulisms, and CDC hemoglobin, electrolyte review, and creatinine coagulation study, and symptoms, pathophysiology, history and physical examination, laboratory tests, CBC, coagulation profile, blood type, and cross-match stool studies, imaging and specialized tests, abdominal X-ray, abdominal ultrasound, upper and lower FGI, contrast studies, endoscopy, treatment based on underlying cause, prognosis, general lab, and condition-specific. Under feature, allergic colitis, necrotizing enterocolitis, intestinal duplication, Meckel's diverticulum, vascular malformation, oral history, and physical examination are critical in the initial evaluation of lower GI bleeding in a newborn. Range of potential cause is broad. Early identification and treatment.